Hello, Partnering for Vaccine Equity Learning community members. We'll get started in just a couple minutes. Well, hello, Partnering for Vaccine Equity Learning community members and others working on vaccine equity, and welcome to this afternoon's learning event. I'm Jenny Haley, part of the group learning team for the learning community. And on behalf of our team at the Urban Institute, thank you so much for joining us. Our session today is entitled Coverage Matters, Understanding and Connecting Community Members to Affordable Health Insurance. This issue is so key to the work that you all are doing on vaccine equity, because health insurance coverage can help facilitate access to vaccines and of course has other benefits for your community's health. Our purpose today is to give you an understanding of health insurance coverage in the US, the types of free and low cost coverage your community members might be able to obtain, and then how they can get more information on those coverage options. In particular, paid-funded organizations and others working on vaccine equity can play a role in helping people access adequate and affordable health insurance coverage. Before we go further, I'll do our typical quick review of how the session will work. You've all been muted upon entry to the session. Please stay on mute unless you're speaking to keep the discussion going without accidental interruptions. Our chat room feature is open today. We encourage you to use it. You can introduce yourself or type a question for our speakers at any time, and then we will reserve some time at the end for Q&A. We do offer live interpretation from English to Spanish during our events. If you'd like to listen to the Spanish language channel, simply click on the globe icon in the Zoom taskbar. It's at the bottom of your screen. Finally, as with all of our learning events, we will of course post the slides and a recording of this event on our community website, and then we'll circulate those through the digests that go out as part of the CDC managed Adult Vax Program listserv, which all program members should be a part of. If you have any technical difficulties during this session, please send an email to our community manager's inbox. That's vaxequitylearning@urban.org. And we'll be watching the inbox and we'll try to help you as quickly as we can. And now it is my pleasure to introduce our two featured speakers. We're really fortunate to have them with us today. First up will be Linda Blumberg. She's an Institute Fellow in the Health Policy Center right here at the Urban Institute. She's an expert on private health insurance coverage, so employer and non-group coverage, healthcare financing, and health system reform. Her recent work includes a variety of projects related to the analysis of the Affordable Care Act, or ACA, efforts to repeal and replace the ACA, and the provision of technical assistance to states in their efforts to analyze and implement new reforms. Dr. Blumberg is frequently consulted by members of Congress and their staffs, as well as major media outlets on issues related to insurance and healthcare reform. She previously served as health policy advisor to the Clinton administration during its initial healthcare reform effort. We are also very lucky to be joined by Karen Politz, who is a senior fellow for health reform and private insurance at the Kaiser Family Foundation. She co-directs the program on patient and consumer protections, examining what consumers and patients face as they navigate the healthcare system, including financial barriers, administrative complexities, lack of transparency, and problems accessing providers. She also works with the program on the ACA, tracking implementation of private market reforms with a focus on consumer protections. Thank you both so much for joining us today. And now, Linda, I will pass it over to you.
Thanks so much, Jenny. And I'm very happy to have the chance to talk with you all this afternoon. Let's advance to the first slide. If we can. Okay, great. So I just want to start by giving a short overview, big picture of what health insurance in the United States looks like. So first of all, almost all people in the United States who are either age 65 or over are enrolled in health insurance through the Medicare program. Sometimes they have insurance through additional options in addition to Medicare, but almost all of them are covered by the Medicare program. So when we're thinking about how to expand health insurance coverage in the United States, we are really focused largely on people under age 65. Among those who are under age 65, a little less than two-thirds, about 62% have private health insurance today. And that is partly people who have employer-sponsored insurance and partly people who buy private insurance on their own, not through an employer. But the largest chunk of that is the people who have private health insurance through an employer, either their own or that of a family member. About 28% have public insurance, and most of that is through the Medicaid program. And about 9% are uninsured. That's about 26 million people. We estimate today it's a little bit under 9%, which actually is a historic low in the United States in terms of the percentage of the population who are uninsured. Let's go on to the next one. So, why be uninsured? Why is it important? Why do we spend so much time in the public policy sphere and in analysis of the uninsured and how to expand coverage to them? Well, we know that if you are uninsured, you have reduced access to medical care. So the cost of medical care, the price per unit of service that you can get from physicians and other healthcare providers are generally sufficiently high that for many services, if you don't have health insurance coverage to help offset the costs, the out-of-pocket costs of obtaining these services, you won't get them. As a consequence, a number of studies and very recent studies have demonstrated that there is a significantly greater risk of dying and having other adverse health outcomes if you survive, if you are uninsured, compared to someone with the same conditions and the same situations who have insurance, whether private or public. So there are very, very substantial and significant health risks that are taken by those who do not have health insurance coverage. Also, we know that because of the high costs of medical care and services, and some services that cannot be avoided, that being uninsured can lead to very high medical bills. And this can lead to very large financial burdens compared to income for people who have to pay for care out of pocket. So the amount of spending that they would have to do in order to obtain needed medical services can be very high relative to their incomes, and this can lead to bankruptcies. It can lead to ongoing debt, as is noted here, that becomes compounded over time as interest rates accrue and late penalties accrue. We also know from a variety of studies that people who are uninsured are less able to be productive in their normal lives, which means that their health issues can be interfering with their ability to work, their ability to go to school, their ability to be as high functioning as they ordinarily would be if they could obtain the medical care that they need to address their health issues. Next. Now, since the Affordable Care Act was passed, this was a little bit wrong. It was passed in 2010, but the great number of the reforms were implemented in 2014. Since then, the number of people uninsured fell considerably. Many more people became eligible for financial help to enroll in health insurance coverage. This was an enormous part of the change brought by the Affordable Care Act. Now, 38 states in the US, plus the District of Columbia, under the Affordable Care Act rules, have made all their legal residents with incomes up to 138% of the federal poverty level eligible for free or very low cost insurance through Medicaid. And just to give you kind of a sense of what this means in terms of income for people, the federal poverty level in the current year is $12,880 for somebody who's living by themselves, a single adult. For a family of four, it's $26,500. So we're talking about the lowest income population in these states have been made eligible through Medicaid under the Affordable Care Act for basically free insurance, free comprehensive insurance. Now, 12 states have chosen not to take on the option of the Medicaid expansion, although Wisconsin has done their own kind of expansion, which is outside of the federal option. They expanded just up to those people with income at the poverty level or below. But while some states, these 11 states in particular, have not expanded Medicaid, in every state in the US, people with income at least as high as the poverty level and who lack access to employer-based insurance are currently eligible for significant financial help to bring the price of a standard private insurance plan down to no more than 8.5% of their income. Next slide, please. And this assistance, as someone's income goes down, people get more help for helping to pay for private health insurance. It's a sliding scale. So the premiums, what someone has to pay every month or per year as a percent of their income, under current rules, the share of their income that they have to devote to get health insurance coverage of the standard type that's offered under the Affordable Care Act, that percent of income goes down as their income goes down. So for example, for those people and families up to 150% of the federal poverty level, the household doesn't have to pay anything out of pocket for the premiums for that for a standard health insurance policy for the year. People between 150 and 200% of the federal poverty level, what they would be expected to pay for a standard policy will range up to 2% of income as their income approaches 200% of the federal poverty level. So you see here by this schedule, as basically linearly as people's income goes up, what they can be expected to be able to afford for health insurance goes up too, until the cap at the top is that no household is expected to spend more than 8.5% of income for a standard policy. Now, this assistance, the subsidies that make this scale possible, were made more generous during the COVID pandemic. And as a new legislation that's just passed, the budget reconciliation bill that you may have read about very recently, these better subsidies, these more enhanced, more generous subsidies for private health insurance have been extended at these higher levels, at least through the end of 2025. So these more generous levels of assistance that I've shown here are going to be extended into the next 3 years as well. So next. Now, in addition to getting help with premiums, the amount that you have to pay per month, per year to buy private health insurance, there is some additional help through the Affordable Care Act that is available to people with incomes below 250% of the federal poverty level. So for these people who are also eligible for the premium assistance, they can get help in addition to lower their out-of-pocket costs. Things like deductibles, co-payments, and co-insurance, which have to be paid by individual consumers out of pocket when they go to seek care, even if they're insured, can sometimes be large enough to prevent people from being able to afford to get care, even though they are uninsured. And so in order to make getting the care more affordable for these very modest income people, the Affordable Care Act provides extra help that lowers their out-of-pocket costs for them further. And this makes the insurance coverage that they can get with this federal assistance even more valuable than it would be otherwise. Next. Now, even so, with a lot of assistance available and people like Karen and I and Jenny and others focusing on these issues all of the time, surprisingly, many of the uninsured out there in the US, that 26 million people we were talking about earlier, still do not know that help is available to them to make insurance coverage more affordable, and thereby helping them with their health outcomes and reducing their financial burdens. So for example, a survey that was done by our colleagues at the Urban Institute last year found that fewer than 1/3 of the uninsured had heard either a lot or some about the fact that health insurance subsidies are available through what are called the marketplace or exchanges, which are places where people can go and look at the options they have and be determined eligible for financial assistance. So of the 26 million people out there, fewer than 1/3 really knew very much at all or anything about the extra financial help. A survey done by the Kaiser Family Foundation, where Karen works, a couple years ago found that only 14% of uninsured people who lived in the states that had expanded eligibility for Medicaid knew that their state had actually expanded eligibility for Medicaid. So very low income people who were uninsured were really very highly unaware that there was basically free insurance coverage that was very comprehensive available to them in their state. However, more than 80% of the uninsured said they'd be likely to enroll if they knew that they were eligible for Medicaid. So there's a real disconnect between people's desire for subsidized health insurance that's out there and available and their knowledge that these options exist for them. We also know from a good deal of research that information that's provided by trusted members of the community, such as yourselves, can very substantially increase the chance that someone will enroll in health insurance coverage. There is so much misinformation that has been spread about these coverage options, and there's also just an inability to reach a lot of people, particularly those who are the most vulnerable, people who live in rural areas, people who are not highly educated, people who are not necessarily native English speakers, people that are not interacting with other public programs. Those are the people that are hardest to reach, and who trusted members of the community providing them with information can do a great job at moving the ball forward in letting them know what's out there and helping them to get insurance coverage. Next. So how can a consumer find out whether they're eligible for Medicaid or subsidies or private health insurance? Well, the federal government runs private insurance marketplaces in many states, and some states run their own. But no matter what state you live in, the federal website, healthcare.gov, can guide consumers to the information that they need to determine their eligibility for help and to get them enrolled. In order to get enrolled, consumers will need an email address and access to a computer to shop electronically. If they can also get help understanding their options and how much help they might be eligible for by talking to what's called a navigator. And these are people who are trained to help consumers understand their options and to get them enrolled. Contact information from navigators in each state can be found at the Find Help link on marketplace websites. So healthcare.gov is really the place to start. And if people need one-on-one assistance, they can get it by identifying a navigator through Find Help. Next. The 12 states that have not chosen to expand Medicaid eligibility thus far, and there's still some hope that some of these will expand in the future, but for now they have not, are Alabama, Florida, Georgia, Kansas, Mississippi, North Carolina, South Carolina, South Dakota, Tennessee, Texas, and Wyoming. Wisconsin is a bit of a special case because they haven't expanded under the Affordable Care Act up to 138% of the federal poverty level, but they have expanded eligibility for their population for adults up to 100% of the federal poverty level, the point at which the subsidies for private health insurance kick in. But unfortunately, this means that many adults with extremely low incomes, those who are technically poor, below the poverty level, will not be eligible for any help with the cost of health insurance in those 11 states unless they are eligible under prior Medicaid, the traditional Medicaid rules. Poor adults who don't have dependent children, excuse the sirens going by. So if for poor adults who don't have dependent children in their households, they're not eligible for help in any of these states, unfortunately. Poor adults with children may be eligible for Medicaid in some of these states, depending upon their circumstances, but the eligibility there even is quite limited. So for example, in the state of Alabama, the cutoff for parents in terms of Medicaid eligibility is 18% of the federal poverty level. It's extremely low. Okay, Mississippi, it's 25% of the federal poverty level. So there's very little in a lot of these states, there's very little eligibility for adults and none for non-parents who are below the poverty level. But for those at poverty and above, they still have eligibility for very considerable financial assistance. Next. So when can consumers get the information on their coverage options? People who are eligible can enroll in Medicaid at any time of year. There's no open enrollment period. For those enrolling in private insurance that they haven't gotten through an employer, most people are going to have to enroll during an open enrollment period, which is in November and December each year. And the plan that they pick would then provide coverage for the next calendar year, January through December. Some people also qualify for what's called a special enrollment period during the year if they've experienced a significant life event like losing private insurance from another source, moving to a new state, losing eligibility for Medicaid because of an income increase, getting married, having a baby, those kinds of things. So some people can qualify during the year, but most will have to go enroll in coverage during the open enrollment period in November and December. Next. So Medicaid enrollment in particular has grown substantially during the pandemic. Under the Families First Act, states were offered enhanced financial federal funds to help pay for Medicaid if they would accept certain conditions. And one key condition was that they needed to suspend disenrolling people from Medicaid, even if they otherwise would lose eligibility under the rules. So even somebody, for example, whose income went up got to keep their Medicaid during the course of the public health emergency. And this rule is going to last until the end of the COVID public health emergency is announced, which we don't know yet when it's going to end, but it will not end before October. At this point, it may go into early next year. We don't know yet. Medicaid enrollment has grown by roughly 20 million people as a result of this continuous enrollment. When states resume determining eligibility for Medicaid, however, this is a risk, and Karen's going to talk more about how we can help prevent this problem, but millions of people may be disenrolled from Medicaid as a consequence when this resumes, and some of those people, many of those people may become uninsured if we're not aggressive in terms of helping them identify what they need to do to stay covered. Next. And so with that, I'm going to turn things over to Karen, and she's going to talk about the COVID-19 vaccines and how insurance coverage relates to access to those and how that might be changing as we go forward.
Thanks, Linda, and good afternoon, everyone. Let's go right to the next slide, please. So when we talk about how to get vaccines and the cost of vaccines, I just want to begin with, there are two components of the cost of a COVID vaccine. One is the vaccine itself, the dose that you get out of that little glass vial. In the United States, vaccine manufacturers basically set their own prices, and then they may negotiate discounts with, the government or with private insurers or with doctors' offices or clinics, and the prices can change over time. And then the second component is the cost of actually administering the vaccine. So a health professional, a doctor, a nurse, a pharmacist, actually, sticks the needle in your arm. They need to have the supplies to give you the vaccine, the capability of storing the vaccine doses safely, and the cost of filling out all of the paperwork. So there's this administration fee as well as the cost of the vaccine dose. And I'm going to be talking about both of those today. Next slide. In terms of the cost of the vaccine dose, so far, the federal government is paying for all of it. The federal government has purchased over 750 million doses of COVID vaccine so far, and they pretty much have bought it all, and they have negotiated bulk discount prices with each of the manufacturers. So initially, the federal government bought, I forget how many 100 million doses from Pfizer at $19.50 per dose. And they paid Moderna $15 a dose because they had contributed more to the R&D costs. So, but right now, all of the COVID vaccine that is out there has been purchased by the federal government. And that direct purchase by the federal government of COVID vaccine is a key component to assuring access to free vaccine for everyone in the United States. I'll talk more about that in just a second. Congress, the Biden administration this spring asked the Congress for another $22.5 billion in emergency funding for COVID, which included money to buy more vaccine. And Congress did not oblige. They refused to pass more money. So for now, the Biden administration has been kind of rearranging and repurposing other existing funds so that they can continue to buy doses of COVID vaccine. The U.S. Just contracted with Pfizer to purchase 100 million doses of a new vaccine for the fall campaign, which will be a new formula based on the Omicron subvariants. And they purchased another 66 million doses from Moderna for the fall vaccine campaign. That won't be enough for everybody who needs a fall vaccine to get one. It'll certainly go a long way. And these agreements included options for the federal government to buy many millions more doses of this new kind of vaccine, but only if Congress appropriates the money. So, but for the time being, all the COVID vaccine that's out there has already been paid for by the federal government, and that is going to continue to be the case at least for another long while. Next slide, please. Now, why does this matter? Because in order for anybody, a doctor, a vaccine, CVS, any provider of COVID vaccine to get this federally paid for vaccine dose, they have to enroll in the CDC COVID-19 vaccine program. And as part of their agreement, when they enroll, they have to promise that they will not charge anybody anything for a COVID vaccine. They won't charge them for the cost of the dose that the federal government already paid for. They won't charge them an administration fee. And they won't deny anyone a vaccine based on whether they have insurance or whether they're in or out of network. When they do have insurance, based on their immigration status, they will just give people the vaccinations unless there's like some medical reason, right? You're not eligible. I can't get the, under 5 vaccine, but they can't charge you anything. The providers who participate in the CDC COVID vaccine program are allowed to ask you for your insurance and to bill your insurance for the cost of the administration fee. But if they can't get that claim paid for whatever reason, or you don't have insurance, they can't come back and ask you for the administration fee. So that's a very important thing, is the federal government, by purchasing all the vaccines and then setting up this kind of distribution program, they have essentially required all providers to agree that they won't charge you anything. And providers that participate in the CDC program include retail pharmacies like CVS and Rite Aid, clinics, public health departments, hospitals, private physician offices. Okay, so that's the rule right now for everybody. Okay, next slide, please. So what happens then for this administration fee, and what are the kind of underlying rules for covering vaccine or for paying for vaccine based on your coverage status and for the uninsured. And I'm just going to kind of walk through these. So this is kind of layers of information. The important thing now is while the federal government's buying it, you can't be charged anything. But down the road, we're going to kind of fall back on some of the traditional sort of rules for insurance coverage for vaccine and how much you might have to pay out of pocket. For private insurance, which as Linda pointed out, most of us have before the age of 65, it's about 175 million people. The Affordable Care Act already requires that private insurance has to cover preventive services with no out-of-pocket costs, so no deductibles or copays apply, as long as you get the care in-network. Those preventive services include vaccines that the CDC recommends through its advisory committee on immunization practices, that's ACIP. Normally, private insurers have within a year after ACIP recommends that a vaccine needs to be covered as a preventive service to actually get around to doing it. But during the pandemic, under the CARES Act, insurers had to hop to it and start covering these vaccines as they became approved by the FDA and recommended by the CDC within 15 days. In addition, while we're in this public health emergency that Linda mentioned, that was first declared by HHS back in January of 2020, and it's been extended in 90-day increments ever since. While we're in this public health emergency, private health plans have to cover the cost of the COVID vaccine and the administration with no cost sharing, even if you go out of network, right? Most of us who have insurance know it's not just Verizon, it's also for health insurance. It's all about the network. So you will only get the full coverage, 100% coverage if you stay in network. But during the public health emergency, you can just go ahead and go to a, pop-up vaccine clinic site that's, at the mall, or you can go to CVS or any place beyond what might be in your normal network of a doctor and other providers in your health plan network. So, okay, and then the last thing that has happened during the pandemic for private insurance, so again, nobody can charge private insurance for the cost of the vaccine itself that the federal government already paid for, but insurers can negotiate what that administration fee is. With their participating providers, insurers negotiate reasonable charges with their participating provider networks all the time. And if you do go out of network, the federal regulations say that the private insurance has to pay a reasonable administration fee, and that what Medicare pays for the admin fee, which is $40 per dose, is reasonable. So the providers can't go back, can't go back and charge more than that. So private insurance has to cover vaccine 100%, even if you go out of network, and there are limits on what can be billed. Next slide, please. Linda mentioned Medicare. I'm almost there. That's what covers almost all of us when we turn 65, and some of us younger if we have a disability before the age of 65. Medicare also fully covers the cost of COVID vaccines. Many vaccines currently are covered under the Part D of Medicare. Medicare is something you buy in pieces, and Part D are these sort of separate prescription drug plans. Not every senior gets one of those. So the CARES Act requires that, I'm sorry, my phones are all going off during this. The CARES Act requires that Part B, which just about everybody has, will cover the vaccines. It'll cover it 100%. No deductible, no 20% coinsurance applies. Again, Medicare doesn't have to pay for the vaccine itself because the federal government already did that. Down the road, Medicare has sort of its own rules for determining the price that it will pay for any vaccine, and those will kind of kick in once the federal government stops buying all the doses. And again, the regs have been established saying that Medicare will pay an administration fee of $40 per dose of the COVID vaccine, including second shots and boosters. Next slide, please. The Medicaid program is our other major source of coverage. As Linda mentioned, that has really grown during the pandemic because states are not disenrolling people. They're only signing them up, but they're not kicking them out. And so we've got close to 90 million people now who are covered under Medicaid and CHIP, much bigger than what we're used to. In all states, Medicaid will cover the cost of the COVID vaccine for the enrollee 100%. The enrollee won't be charged a copay or deductible or anything else. All states agreed to that as another condition for accepting this boost in payments that they were offered during the pandemic. And this requirement to cover COVID-19 vaccines 100% with no cost sharing to the beneficiary will continue into perpetuity for most beneficiaries. A few may become liable for small copays after the public health emergency ends, but states have to just suspend all cost sharing for at least a year after the public health emergency ends. And as Linda said, that's currently slated to end in mid-October, but the administration has already signaled that they will renew it for another 90 days. So the public health emergency is going to go at least into 2023. And then one last piece on Medicaid, the Families First Act and the CARES Act, the two kind of emergency COVID response pieces of omnibus legislation, gave states the option to create a special Medicaid eligibility category just for their uninsured residents that will just cover COVID testing, treatment, and vaccines. And so far, 15 states have elected that option, and that option will continue also as long as the public health emergency is in effect. Next slide. Okay, so if you're uninsured, again, federally purchased vaccine, no one can charge you anything. But the providers of vaccine are allowed to bill programs for the cost of that admin fee. And that's important because that means that the provider doesn't have to eat the cost. And so there's no incentive to kind of turn people away or to not be available to them even informally. So we had $100 billion, I think, program that was set up within HRSA to just provide extra money to hospitals and doctors and other providers during the pandemic for the additional costs that they were incurring, and that also reimbursed providers for COVID services, including that vaccine administration fee. That program just ran out of money this spring, so that has closed. But I wanted to mention that because folks may just now be sort of seeing some doctors sort of noticing that they can't get that $40 a dose anymore. We also have two other kind of federal programs that make free vaccines available. There's the Vaccines for Children program. That will cover, I don't think it's officially been added, but it will soon cover the costs of COVID vaccines for kids up through age 18. So people can still access a free COVID vaccine through their kids through that program, as well as, polio, rubella, everything else. There's a smaller CDC Section 317 vaccine program for uninsured adults. That's a very small program. It has limited money. It tends to run out at the end of the year, but that is, out there as well. And some providers can tap into that. And other sort of safety net providers, including federally qualified health centers, free community healthcare clinics that provide free or low-cost care to the uninsured. Those are places where people can get a free vaccine. So the uninsured, I think when in doubt, call your public health department to find out where it is that you can get the free vaccine. And where these different programs are likely to be there to support the providers of vaccine. Next slide, please. So what happens when the supply of federally purchased vaccine runs out? We're all a little nervous about that, and nobody knows the answer. But a couple things are likely to happen that will sort of begin to create exceptions to that very kind of comforting, nobody can be charged anything ever for COVID vaccines. So one is that the cost of vaccine doses is probably going to go up. The federal government has, as I mentioned, paid Pfizer at the outset $19.50 a dose for the first couple 100 million doses of COVID vaccine that it bought. For the next 100 million that it has pre-purchased for the fall vaccine, Pfizer negotiated a higher price, $30 a dose, for this kind of new vaccine formula. But manufacturers have signaled that when the federal government stops directly purchasing vaccine, that they're going to go back to setting prices the way they used to, which will be much higher. And then anyone that wants to negotiate a discount, whether it's CVS or Blue Cross or IBM's health plan or whomever, these prices are just going to get bid up. So the cost of vaccine is going to become greater when the federal government stops purchasing it. And because when the costs get bid up, that may make it harder for these safety net providers, including clinics, to be able to secure enough supply, to afford to secure enough supply of COVID vaccine for the patients that they serve. Also, when the federal government stops purchasing vaccine, that CDC COVID vaccine program, that will end. So at that point, providers will be allowed to charge uninsured people for the cost of a vaccine and to refuse to give it to them if they can't pay. So the end of federal purchase of vaccine, I think, could create a material difference in terms of access to free or even affordable vaccine for people who are uninsured. And in terms of vaccine equity, something I keep talking about these safety net providers, but the federal government spends many tens of billions of dollars every year on federally qualified health centers, these community health centers, and they provide free COVID vaccine to people as well. And HRSA, the agency that oversees that program, has enlisted a subset of these federally qualified health clinics around the country, about 900 of them, that really serve a disproportionate number of racial and ethnic minorities, people with limited English proficiency, immigrants. And they have sort of prioritized these clinics in their formula for distributing the vaccine that they have made available. According to HRSA's website, so far HRSA has published about 21 million, has gotten access to 21 million doses of vaccine that the federal government purchased, and 70% of those distributed by these federally qualified health clinics have been given to patients who were racial and ethnic minorities. So when the federal vaccine program ends, all of these dynamics could start to change. Next slide, please. The other thing that I wanted us to all keep an eye on is this public health emergency, because there are sort of additional protections in terms of what people can be charged in terms of copays and deductibles for vaccines, even if they go out of network. Right now, none of that is allowed during the public health emergency, but when that ends, we could start to see other things happen. Most importantly, as Linda mentioned, states have agreed to suspend disenrolling anybody from Medicaid during the public health emergency. But when that ends, states are going to resume annual kind of redeterminations. So you don't sign up for life for Medicaid the way you do for Medicare. You generally sign up for 6 months or a year at a time. And states are going to go back and they're going to ask all of those 90 million people to fill out a form and say, what is your current income and what is your current age? And, give me the information that I need to determine if you are still eligible for Medicaid. And the expectation is that 10 million or more people could get knocked off the Medicaid program, either because they don't qualify any longer, their income has gone up, or maybe they turned 19 and so they don't qualify as a child anymore and they live in one of those gap states, or because they just didn't know that they were supposed to fill out the form. People don't know that Medicaid is out there to begin with, so they don't always know, they don't always receive the form. It might get sent to the wrong address, and they just may not fill it out in time. So we're all kind of bracing for the end of the public health emergency and worried that millions of people who are currently comprehensively insured by Medicaid could all of a sudden become uninsured. So it's going to be really important to remind people that you work with, that who have Medicaid coverage, to stay on the lookout for those redetermination notices from the state once the COVID public health emergency ends. And then for privately insured people, and as well as for folks on Medicaid, it could be that people would go back to having a copay or a deductible applied to the cost of their COVID vaccine if they don't stay in network. So, and then for the uninsured, I'm just worried that access to COVID vaccines will become much more limited once the federal government stops buying and once the public health emergency ends. So, last slide, please. What can folks do to help with all of these upcoming transitions? I think importantly, when you meet somebody who is uninsured, really encourage them to explore whether they can get coverage. The majority of people who are uninsured are eligible for free or low-cost coverage. And as Linda pointed out, a lot of people just don't know that. So I think anytime you find somebody who is uninsured, first help them get an appointment for a free COVID vaccine, and then stick with them and see if you can help them sign up for coverage. If they qualify for Medicaid in their state, they can sign up at any time during the year. Medicaid is always open to enroll 365 days a year. And if their income's a little higher, or they live in one of those gap states and they have income at least the poverty level, they can sign up through the marketplace. That generally you can only do during open enrollment, but that's coming up. This November 1, open enrollment will begin in every state for marketplace coverage. That starts in January of 2023. And then if you know people who now, or you encounter people who have Medicaid coverage already, it will be very, very important to remind them that when the public health emergency ends, it hasn't ended yet, it'll be probably sometime next year, and there'll be a lot of publicity about that. But when it ends, people really need to pay attention to the mail, their email. If they haven't heard from their state Medicaid program, reach out and make sure that their state Medicaid program actually knows how to find them, so that they can go through the eligibility redetermination process and hopefully keep their coverage. And if not, figure out where they can go next, presumably into a marketplace plan. Again, there are coverage options for almost all of the uninsured. I'm sorry, it's so complicated. It's not my personal fault, but people do need help figuring out all of these rules and signing up and enrolling. And there are professionals, navigators in the marketplace who are there to help people with all of this, including signing up for both Medicaid and for marketplace coverage. So I think we will stop there and see if there are any questions.
Thank you both so much for all that comprehensive information. And no, we will not hold you accountable for all the complexities of that. So
Thank you.
I really appreciate it. So folks, feel free to put any questions you have for Linda or Karen in the Q&A box and they can answer them. I will kick it off with one question is, could you talk a little bit for the organizations who might work with immigrants about, the extent to which immigrants might not be eligible for programs, and any thoughts on what they could do to access any coverage or vaccines?
Sure, I'll jump in with a little information and Karen will correct me where I'm wrong. So a lot depends on the circumstances of the particular immigrant. People who are here without documentation, unfortunately, are not eligible for the insurance subsidy programs, although they are eligible at the current time for free vaccine coverage. So nobody, regardless of documentation status, is being barred from access to free COVID-19 vaccines. With regards to recent immigrants who are here with documentation, people who either are here as refugees or asylees, or who were evacuated in the emergency evacuation from Afghanistan, those folks are all eligible for Medicaid without any waiting period. So that is special circumstances for refugees, asylees, and what are being called parolees, the emergency evacuees from last year from Afghanistan. People who are here with documentation as immigrants who have not been here for 5 years, who don't fall into the asylee, refugee, parolee category, are eligible for, potentially, depending upon their income, for subsidized health insurance through the marketplaces, the private health insurance subsidized option, but not Medicaid until they've been here for at least 5 years. So even if their income would suggest that they are eligible for Medicaid, they won't be eligible for Medicaid in I think in any state until they've been here for 5 years, but they can get subsidized private health insurance. And then those who have been here for 5 years or more who meet the Medicaid eligibility rules are eligible for Medicaid. Did I miss anything, Karen?
No. So one way or the other, immigrants who are here with documentation should be eligible for something, either Medicaid with or without a waiting period, depending on their status, or marketplace. And immigrants who are here, who have very low income, even below the poverty level, normally marketplace subsidies start with people when people have income of at least the poverty level, but immigrants in that Medicaid waiting period can qualify with even lower. So it's just the undocumented who are really stuck. But as Linda said, for now, COVID vaccines are available free to everybody, regardless of your immigration status.
Thank you. We have a question in the Q&A. Do you know of any funding opportunities for navigators to address the 10 million people who may need help to switch from Medicaid to marketplace coverage?
So I can start with that one. The federal government this year increased the payment for navigators in the healthcare.gov states, which is most of the state marketplaces, increased it a lot. That funding had been kind of obliterated during the Trump administration, and the Biden administration put it back and then some. So, and they made a separate supplemental award this year, anticipating that the public health emergency might end this year. Now it looks like it's going to go into next year. And any day now. They haven't announced yet, but the federal government will, in the next week or two, announce the awards for navigators for next year. And that is also expected to include a boost because of the public health emergency unwinding and people needing this additional help transitioning with their Medicaid, either trying to stay in or having to transition through the marketplace. And we just surveyed the states. This isn't out yet, but it looks like the states have all kind of maintained or improved their funding for navigators as well. And then finally, CMS had a separate funding award. It was earlier this summer. I think it was $25 million through the Covering Kids program. So I think CMS is aware and is trying to make more resources available for the navigators that will help people out. A lot of people who go to the marketplace to buy for coverage will work with a private health insurance broker. And sadly, in fact, healthcare.gov has been set up, and they haven't changed this yet, to kind of steer you to brokers. The first thing you see on Find Local Help is all this information about how to connect with a private health insurance broker. And you have to really kind of dig down to get to the information about the navigators. Hopefully they'll fix that soon. And it's fine to work with brokers. There are very many nice brokers out there, but what our survey finds is that the brokers tend not to be as good at helping people sign up for Medicaid because they don't get paid when they sign up someone for Medicaid. They work on commission. So they tend to be very proficient at signing you up for the private insurance coverage and getting the subsidies that Linda talked about there. And more likely if someone comes and it turns out they're eligible for Medicaid to say, I can't really help you with that. Go find a navigator. So start with a navigator if you can. And just be ready for the fact that these can be kind of lengthy applications. It typically, an appointment with a navigator lasts at least 45 minutes, and you have to have assembled, kind of information ahead of time, your immigration papers, if that's an issue, your social security number, your most recently filed tax return. So it's a somewhat involved application. It's not something you can just click on your phone in 10 minutes like you were buying a ticket to a concert. So just don't wait to the last minute and just take a deep breath and be ready for the fact that this will take a little bit of doing, but the navigators are very smart and they know what they're doing, and they will help you through this whole process and help you get everything done. Linda was just working with she and I were talking offline last week, trying to help somebody who had a complicated immigration case. And once she connected with the right people at the exchange, they got it all settled. So there are people that know how to help you with this, and they are ready to do so.
That's fantastic. Thank you. Well, we're almost at time. So really want to express our appreciation to you both for being here today, and for our attendees, wanted to highlight a few upcoming events. We have our advocacy learning series, and the webinar associated with that is this Wednesday. So sign up for that if you haven't already, and then we'll have a workshop following that. Our social media workshop series has a wait list, but if you'd like to be put on the wait list, feel free to email us. And then on August 31st, we have an event by the National Hispanic Medical Association. So look forward to seeing any of you who could join us at any of those. We will have a quick satisfaction poll that will pop up. If you don't mind answering that before you leave, then we would very much appreciate that. But since we're now at 3, we will let you go. And a huge appreciation again, Linda and Karen, to you both for joining us today. Really helpful information.
Thank you all.
Yes, thanks very much.